Welcome to the EAU podcasts. In this episode, our UROONCO RCC editorial board gives us a summary of the kidney cancer developments in the year 2024.
Welcome to the take-home message 2024 on the UROONCO platform for kidney cancer. We had a major data release this year, 2024. It was a very productive year from the kidney cancer side. I am joined today as my role as chief editor. I am Maria Carmen Mir, and I'm joined by Teele and Riccardo Bertolo as my associate editors. We will discuss for the next 10 minutes what's been happening over this last year in terms of kidney cancer. So we had a few articles of the month this year, but we wanted to highlight a couple of them that came out recently. One is about SBRT, and Teele, can you give us some thoughts about what was released?
Yes, thank you, Carmen. This was FASTRACK trial, which was the very first phase 2 international trial to treat primary up to 10 centimeter kidney cancer with SBRT. And it was published this year in Lancet Oncology. And this trial included 70 patients who were inoperable. The median size of the tumor was 4.6 centimeter and median follow-up for these patients were 43 months. These patients did not experience cancer-related deaths. Their toxicity was very low, and also GFR decrease was up to 14 millimeter per minute only. So optimal candidates for SBRT are those who are medically inoperable or technically high risk or have high risk for dialysis postoperatively. However, there are also some challenges with SBRT, such as, for example, assessing recurrence requires experience. And first of all, during the first scans, there could be some pseudo-progression and also hyper-enhancement, and therefore it requires some expertise. Also, we are not aware of long-term results, and we don't know if, for example, secondary malignancy for younger patients could be an issue. And hence, it could be considered for patients who are borderline currently for ablation of surgery.
Good to hear. So we have one more tool to play with as urologists then. And so the other article of the month that we wanted to highlight was the release of the ZIRCON trial. Do you have any insight on that, Riccardo?
Yeah, thanks, Carmen. We know that the ZIRCON trial was an open-label, multi-center clinical trial where a group of patients with indeterminate T1 renal masses underwent this novel molecular imaging, zirconium girentuximab PET-CT, trying to understand without a biopsy the origin, the histological origin of the lesion to be treated. Definitely the authors deserve recognition for conducting such a prospective study because it addressed diagnostics in small renal masses. And the trial tackles this critical issue of overtreatment in such patients. It is important to note that this PET targets, the zirconium girentuximab targets the carbonic anhydrase 9, which is expressed in clear cell renal cell carcinoma, but it does not detect other subtypes. The control for the PET results in the trial was histopathology, obviously, and with the positive predictive value of more than 90%, a positive result strongly suggested true disease present in the trial. But about 7% of the patients with clear cell renal cell carcinoma still were at risk of facing overtreatment, such as surgery or ablation, if no other diagnostic test was performed to confirm the actual histology of the detected lesion. The more concerning finding in the trial is the negative predictive value of 75%. That means 1 out of 4 patients with negative PET may still have the disease. Therefore, a negative scan cannot reliably rule out the malignancy in such patient. highlighting that there's still a limitation in the widespread adoption of such tests alone.
Thank you, Riccardo. So my question is for you, would you offer this tool to your patients for diagnosis right now?
Thanks for the question. Definitely logistic for this specific PET-CT is an issue. We started our experience with SESTAM-EB PET, but in many cases of multiple lesions, synchronous multiple bilateral lesions, still has some issues. So I would not consider to imply this PET-CT, zirconium girentuximab PET-CT, without structured after PET diagnostic text to corroborate the finding of such examination.
Thank you, Riccardo. So after the article of the month, we wanted to highlight the major release of the year that was at ASCO GU. The data from KEYNOTE-564, the adjuvant trial that we had this year, was released, and it was actually deeply discussed. Teele, can you tell us a little bit of what's happening on the adjuvant environment for kidney cancer?
Yeah, thank you. Well, this was a big release. So the KEYNOTE-564 trial is the only and the very first adjuvant trial that was finally positive also for overall survival. It reported significantly improved disease-free survival and also overall survival with adjuvant pembrolizumab in localized clear cell RCC with high risk of relapse. At 57-month follow-up, overall survival reached significance with 141 deaths, from which 55 in pembrolizumab arm and 86 in placebo arm. So the authors definitely could be commended for such a breakthrough. But I think that there are still very many challenges with adjuvant treatment. Firstly, of course, overtreatment. So a substantial proportion of patients who are cured by surgery only are receiving unnecessary treatment. And then there's also toxicity of 18.6% grade 3 to 4 adverse events which are related to the treatment, and 21% require treatment discontinuation for these AEs. And also there are also a risk of life-changing toxicities. Thirdly, also there are negative trials which need to be considered and definitely discussed with the patients. And also that immunotherapy, monotherapy or combination therapy for recurrence during or shortly after adjuvant pembro cannot be used anymore. And last but not least, there is still lack of biomarkers to predict outcomes and also AEs. So there are still challenges, but definitely the authors could be congratulated.
Thank you, Teele. Nice summary, because there's a lot happening in this field and we're still deciding what is the best approach. However, we have to highlight that multidisciplinary team decision is the best approach finally. Let's move into the surgical new updates, new tools that we have so far this year. Riccardo, can tell us a little bit about the new platforms, what's happening in that area?
Actually, as UROONCO platform this year, we were lucky. We had the privilege of talking next to big names at EAU24 in Paris. We had the privilege of interviewing Professor Motrigi about the current state and future direction of robotic surgery in the field of RCC. We began by discussing the advancements in his robotic partial nephrectomy across his career. Notable improvements are including nowadays reduced need for clamping, maybe thanks to 3D reconstruction technologies, anatomical resection, and minimized till avoided brainopathy. These advances are particularly key in at-risk patients. Next, we explored the developments in robotic platform. We have DaVinci 5 available in the United States, a novel multi-arm platform by DaVinci, by Intuitive, the DaVinci SP, striking a balance between the indication for multi-arms versus single port nowadays is crucial if you have the two technologies. The SP platform has recently been introduced in Europe and is expected to enhance the adoption of the retroperitoneal access to the kidney, which has remained limited adoption with multi-arm robotic surgery. And beyond the DaVinci systems, we delve also into emerging multi-arm platforms like UROONCO versus these systems aim maybe to democratize robotic surgery in different countries at different incomes level. Interestingly, during ERUS 24 with Mr. Ben Chalacon, we tried to discuss the specific indication of this novel platform if you have all of them available. And we end up with discussing that if you have to decide on the optimal platform, this will depend heavily on the patient's need, the kind of disease, the surgical approach required, and the expertise you have. Finally, with both the experts, we look at the future of robotic surgery in general, particularly the potential of telesurgery, telementoring, very popular topics nowadays. And with advances in internet connectivity and development of novel platforms mentioned, specifically designed for telesurgery, this will likely revolutionize the field further, we think.
Thank you, Riccardo, for the summary. It's a lot happening in terms of upgrades in surgical tools. It's happening very fast. AI is helping a lot. 3D is also coming in the picture. Seems like it's actually helping quite a lot. So we will have to see in the following years. Finally, I just wanted to highlight what we got at ASCO 24. After ASCO GU, we got the release of the data from the adjuvant atezo trial that for urologists sometimes is cumbersome. So what was released was the data on the biomarkers, KIM1 kidney injury molecule, quite unknown for urologists, but it's the first time that actually some data is released in terms of biomarkers. I don't know what you guys think, but I think it's a lot to come in the next year about biomarkers that will help us, as Stella mentioned, to determine which patient better deserves adjuvant therapy versus which one doesn't, which I think it's encouraging and it will help a lot in our decision making. Thanks a lot for listening. This is all from our end. I hope we got you summarized for the year and you have a wonderful 2025. Stay tuned for our kidney cancer updates.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.